പറഞ്ഞ നമ്മുടെ ബ്ലഡ് ക്ലോട്ടിംഗ് റിലേറ്റഡ് ആയിട്ടുള്ള കാര്യങ്ങളായിട്ടാണ് ഇതിൽ വരുന്നത്. അപ്പോൾ ഇവിടെ ഞാൻ ഡിസ്കസ് ചെയ്യാൻ ഉദ്ദേശിക്കുന്നത് ഫാർമസിസ്റ്റിന്റെ റോൾ, മെയിൻലി ഫാർമസിസ്റ്റ് ആസ് എ ക്ലിനിക്കൽ ഫാർമസിസ്റ്റ് എന്താണ്, എങ്ങനെയാണ് മോണിറ്റർ ചെയ്യേണ്ടത്, എന്തൊക്കെയാണ് ഡിഫറെന്റ് മെഡിക്കേഷൻസിന്റെ ഡോസിങ്, അതുപോലെ മോണിറ്ററിംഗ് പാരാമീറ്റേഴ്സ്, പേഷ്യന്റ് കൗൺസിലിംഗ്, ഇതുപോലുള്ള കാര്യങ്ങളുടെ ഒരു ബ്രീഫ് റിവ്യൂ ആണ് ഞാൻ ഉദ്ദേശിക്കുന്നത്. So let us go to the slide. So basically, what are anticoagulants? These are the medications used to prevent blood clot with patients with high clot, with the risk of clot. Sorry. So these medications have very narrow therapeutic window. So what is narrow therapeutic window? If any change in the dose or frequency from the optimum dose, there may be a risk of bleeding for the patient. So we need careful assessment before initiating any therapy with any anticoagulant. That means, for example, if the patient in the renal parameters, liver function test, കാര്യങ്ങളൊക്കെ നമ്മൾ അസസ് ചെയ്യണം. അതിനുശേഷമുള്ള നമുക്ക് എന്ത് ചെയ്യാൻ പറ്റുക, ആന്റികോയാഗുലന്റ് മെഡിക്കേഷൻ ഇനിഷ്യേറ്റ് ചെയ്യാൻ പറ്റും. So these medications, they are used to variety of indication. What are the indications we use for the anticoagulants? These are used for treatment of thromboembolism, in case of prevention of thromboembolism, atrial fibrillation, and in case of mechanical valves. So I will go in detail in the coming step. Before going to that, this will give you a brief about the brief explanation about how the evolution of the anticoagulant in the therapy. So it started with the unfractionated heparin in early 1930s. The unfractionated heparin, which is the first one introduced into the therapy. Then after in 1940s, the vitamin K antagonist, that is the Warfarin, it came to the market in 1950s for therapeutic use. Then after that, it took a long gap until 2010. There were no any other oral anticoagulant came to the market. So in between 1980s to 2000, other parenteral anticoagulants also introduced into the market. So finally, it took many decades to get a specific oral anticoagulant after the warfarin. So in 1940s, vitamin K antagonist 1940s almost 70 years എടുത്തു പിന്നീട് ഒരു ആന്റികോയാഗുലന്റ്, ഓറൽ ആന്റികോയാഗുലന്റ് ഡെവലപ്പ് ചെയ്യാൻ. ഈ ഫാക്ടർ 10 ഇൻഹിബിറ്റേഴ്സ് ആണ് റിവറക്സബാൻ, അപെക്സിബാൻ, എൻഡോക്സബാൻ, അതുപോലെ ഡയറക്ട് ത്രോംബിൻ ഇൻഹിബിറ്റർ ലൈക്ക് ഡാപിഗാറ്റിൻ. ഈ 4 മെഡിക്കേഷൻസ് ആണ് ഇപ്പോൾ വൈഡ്ലി നമ്മൾ യൂസ് ചെയ്തുകൊണ്ടിരിക്കുന്നത്. So this will give you a brief review about how each medication acts, how it is influenced in our clotting mechanism. So our clotting mechanism has 3 pathways: intrinsic, extrinsic, and the common pathways. So first of all, the first drug, warfarin, which act by inhibiting the vitamin K dependent clotting factors, which are the 9, 10, 7, and 2. So it has influence in, the warfarin has influence in all of the clotting pathways, both in intrinsic, extrinsic, and common pathways. The factor 10 inhibitor, Apexiban, Endoxaban, Rivaroxaban, and the Bitrixaban is a newer agent. It acts by inhibiting the factor 10A. Factor 10A is responsible for converting the factor 2 to factor 2A, that is thrombin. This is a part of the common pathway. And finally, the direct thrombin inhibitor, dapiglutide. This acts by inhibiting thrombin, that is the final step, which is responsible for conversion of fibrinogen to fibrin. So before we go to each individual drugs, we need to discuss in detail about warfarin, because it has very narrow therapeutic index. So before discussing about warfarin, we need to know the importance of INR. So what is INR? INR is the measure of how much or how long it takes the blood clot when an oral anticoagulant is used. For example, if the INR is 2, the blood is taking twice as long as the normal to clot. So everyone need unique dosage of anticoagulant. So it depends upon the each individual. The dosage of anticoagulant is unique or different for each individual, depends upon the patient's specific character. The therapeutic range of INR also varies and depends upon the disease condition. It's normally the normal INR ranges from 2 to 3.5. In some cases, it is 2 to 3, and in some cases, it is 2.5 to 3.5. And also, it is very important to keep INR within the therapeutic range. So, നമ്മൾ പറഞ്ഞു തെറാപ്യൂട്ടിക് റേഞ്ച് ഓരോ ഡിസീസ് സ്റ്റേറ്റിനനുസരിച്ചിട്ട് ഓരോ തെറാപ്യൂട്ടിക് റേഞ്ച് ഓഫ് INR സെറ്റ് ചെയ്തിട്ടുണ്ട്. ഇപ്പൊ നോർമൽ വീനസ് ത്രോംബോ എംബോളിസം, പൾമണറി എംബോളിസം പോലുള്ള കേസിലാണെങ്കിൽ അത് 2 to 3 ആണ്. ഇപ്പൊ അതിന്റെ ടാർജറ്റ് INR 2.5 ആണ്. ഇപ്പൊ ഇത് വളരെ ഇമ്പോർട്ടന്റ് ആണ് പേഷ്യന്റിന് ഈ INR റേഞ്ചിനെ കുറിച്ചുള്ള ഇൻഫർമേഷൻ, അല്ലെങ്കിൽ INR എങ്ങനെ കറക്റ്റ് കീപ്പ് ചെയ്യുക എന്നുള്ളതിന്റെ ഡയറ്ററി, അതുപോലെ അവരുടെ മെഡിക്കേഷൻ, ഈ കാര്യങ്ങളൊക്കെ പേഷ്യന്റിന് കൗൺസിൽ ചെയ്യുക എന്നുള്ളത് വളരെ ഇമ്പോർട്ടന്റ് ആണ്. കാരണം ഇഫ് ദ INR തെറാപ്യൂട്ടിക് റേഞ്ചിന് മുകളിലാണെന്നുണ്ടെങ്കിൽ, if it goes upper limit, there is a high chance of risk of bleeding, and if it is below the normal limit, patient has a chance of coagulation disorder. So how we calculate the INR? So for calculating INR, we need the patient's prothrombin time. From the patient's prothrombin time, we can calculate INR by patient prothrombin time divided by patient mean prothrombin time raised to the power ISI. What is the ISI? This is the International Sensitivity Index. This is given by the manufacturer for the which particular reagent we are using. So from this, we can have this is a constant value for each lab, for each patient. And patient prothrombin time mean normal is the mean of the patient for a particular lab for a healthy adult 30 to 40 patients in the 30 to 40 adult patients in the average prothrombin time and mean normal. So from this data, we can calculate the INR. So we cannot initiate or we cannot have the warfarin therapy without INR. So what is the therapeutic range of warfarin? Warfarin, we mentioned that warfarin has a very narrow therapeutic range in comparison to other oral anticoagulant. If the INR is more than 4, the patient may be a high bleeding risk, and if it is less than 1.8, that indicates there is a loss of efficacy of the medication or the treatment. And warfarin is most commonly used for prophylaxis and treatment of venous thromboembolism, prophylaxis of thromboembolic complications, of atrial fibrillation, or in case of cardiac valve replacement. So majority of indications like venous thromboembolism or atrial fibrillation, the targeted INR range is 2 to 3. നമ്മൾ പറഞ്ഞ പോലെ INR range എന്ന് പറയുന്നത് between 2 to 3.5 ആണ്, depends upon the disease state. So ചില disease സ്റ്റേറ്റിൽ like venous thromboembolism or atrial fibrillation, ഇതുപോലുള്ള സ്റ്റേറ്റുകളിൽ ഡിസീസ് സ്റ്റേറ്റുകളിൽ INR range എന്ന് പറയുന്നത് 2 to 3 ആണ്. So our target is 2.5. So we have to adjust the dose of warfarin until we attain the targeted dose. In case of mechanical valve or valve replacement, the targeted INR is in between 2.5 to 3.5. So the target will be around 3. Now I will go little detail about the frequency and monitoring of warfarin therapy. After initiation of therapy, in patients, we need to monitor the frequency daily. And in outpatient, there are two kinds of initiation. We can initiate in outpatients in two different ways. One is outpatient flexible initiation, and other one outpatient average daily dosing method. So what is outpatient flexible initiation? This usually we do the healthy individuals, those who don't have any other risk or those who are not very sensitive to warfarin. Warfarin sensitive patients means aged patients weight less than 45, age above 75, other interaction medications used in the end-stage renal disease, chemotherapy patients, cancer patients. These patients are included in the sensitive patients. So other healthy individuals, we can give daily outpatient flexible initiation. That is, we can give a dose of higher dose, like 7.5 to 5 to 10 milligram. In these kinds of patients, we need to monitor the INR daily until the day 4. Daily, we need to monitor the INR. Then within 3 to 5 days. Outpatient average daily dosing method. Average dosing method, we use average dose as 5 milligram. In this case, we need to monitor every 3 to 5 days until the INR is lower the limit of therapeutic range. Then within the 1 week. So these are type initiation, but commonly we use the outpatient average daily dosing method. That is usually 5 milligram as an initial dose. Then after hospital discharge, in case of stable patient, 3 to 5 days, we need to monitor the INR. And unstable patient, 1 to 3 days. In first month of therapy, at least weekly, every week, we need to monitor the INR in the first month of therapy. These all for the initiation therapy. Initiation means those patients not used warfarin before, and we are just initiating the warfarin as a new medication. And the frequency and monitoring for maintenance therapy. Maintenance therapy, these patients are already on warfarin for a long time, and for some reason, it may be held for some reason over anticoagulation or hospital admission, some of the reason if they have held the warfarin dose. So these kind of patients, if they are medically stable, we need to monitor 1 to 3 days. Medically unstable inpatient. Inpatients in the daily we need to monitor. Then after hospital discharge, stable patient 5 to 7 days, and unstable patients 1 to 3 days. Routine follow-up in medically stable and reliable patients, 1 to 2 weeks. And dose held for significant over anticoagulation. Either patients in the over anticoagulation means INR out of range or bleeding risk vannadinu shesham angane nammal dose held cheyidittunde caseilannundengil we need to monitor every 1 to 2 days. And if you have done dose adjustment today, we need to monitor every 1 to 2 weeks. Dosage adjustment less than 2 weeks ago, every 2 to 4 weeks. So ഇത് വളരെ കോംപ്ലിക്കേറ്റഡ് ആണ്. അറ്റ് എ ഗ്ലാൻസ് ഇതെല്ലാം ഓർത്തിരിക്കാൻ ബുദ്ധിമുട്ടായിരിക്കും. പക്ഷെ ഇതിനെല്ലാം കറക്റ്റ് പ്രോട്ടോകോൾ ഉണ്ട്. അപ്പൊ നമ്മൾ ആ ഒരു പ്രോട്ടോകോൾ വെച്ചിട്ട് ഫോളോ ചെയ്യുന്നത് മാത്രം. Now we go in detail about warfarin dosing. So as I mentioned before, as the average, there are two flexible and average daily dosing method. So in average, this is in average dosing method, we will give 5 milligram once daily for most of the patients. You can start a higher starting dose or lower based upon the patient specific characters. The lower dose, usually you go for lower dose in warfarin sensitive patients, and non-sensitive patients, you can go to the higher dose. So what will happen after the first dose you will see after 24 to 48 hours after the first dose, you will see an elevated INR. The reason for this is the depletion of factor 7. So നമുക്കറിയാം warfarin act ചെയ്യുന്നത് vitamin K dependent clotting factor inhibit ചെയ്തിട്ടാണ്. Factor 7, these include factor 7, 2, 9, 10. But factor 7 has a lower half-life. So after initiation of therapy, within 24 to 48 hours, INR, elevate INR change in the ganam, but it is not the actual therapeutic INR. So we need to wait for another 2 to 3 days until the other factors 2, 9, 10, until it deplete 2, 9, 10. So it will take, because they have a longer half-life. So we need to wait until 2 to 3 days to get the actual INR. So after initiation, after 2 to 3 days, you will get the exact INR of the patient. In case of high-risk patient, we should give another parenteral anticoagulant like enoxaparin until the therapeutic INR is attained. Well, we will call it bridging therapy. We will bridge with the enoxaparin until the desired INR is obtained. And then once we reach the desired INR, we can discontinue the parenteral anticoagulant. This is also something more. This is extra information about the dosing. So if our target INR is 2 to 3, this is for the warfarin dose initiation. I'm talking about the initiation. If our targeted dose INR is 2 to 3, in standard dosing for patients who are not expected to be sensitive to warfarin. So normal patient, warfarin sensitive allada patients in the case initial dose, നമ്മൾ പറഞ്ഞു 5 milligram daily for 3 days ആണ് യൂസ് ചെയ്യുന്നത്. In case of sensitive patients ആണെങ്കിൽ 2.5 reduced dose നമ്മൾ കൊടുക്കണം. After 2 to 3 days, we will check the INR. If it is still less than 1.5, so our target is in between 2 to 3. So if it is less than 1.5, still the patient is under risk. So we need to increase the dose, 7.5 to 10 milligram for another 2 to 3 days. If it is then after that, or if after the initial dose, if you see 1.5 to 1.5, 1.9, the dose, you can continue the same dose, what you initiated, 5 milligram daily for another 2 to 3 days. Still, you need to check the INR after 2 to 3 days. If it is in between 2 to 3, still we need to give, we need to continue the warfarin, but we can give a reduced dose of 2.5 milligram for another 2 to 3 days. And if the INR is above the targeted range, 3.1 to 4, it's not advisable to stop the warfarin, but instead you need to still reduce the dose to another 1.5 milligram daily for another 2 to 3 days. And then you monitor the INR. If it is more than 4, hold the INR until it reaches 3. You hold the warfarin until the INR reach less than 3. So ഈ ഒരു രീതിയിലുള്ള കോംപ്ലക്സ് ഡോസിങ് മോണിറ്ററിങ് ആൻഡ് ഡോസ് ചേഞ്ചിങ്ങിലൂടെയാണ് നമുക്ക് ഫൈനലി നമുക്ക് ഡിസൈഡ് INR നമുക്ക് അച്ചീവ് ചെയ്യാൻ പറ്റും. അതിനുശേഷം ആ ഡിസൈഡ് ഡോസ് കണ്ടിന്യൂ ചെയ്യാം. So now we will go to the warfarin maintenance dose. The usual maintenance dose is 2 to 10 milligram once daily. So it can be any dose. This depends upon the patient's specific characters, weight, sex, age, or whatever. So once the INR is stable after following initiation, we have to follow the maintenance dosing protocol to continue the maintenance dose. In this case, the INR should be checked at least weekly when it is out of range, and approximately every 4 weeks once therapeutically stable. So നമ്മൾ ആദ്യം ഡിസ്കസ് ചെയ്തത് ഇനീഷ്യേഷൻ ആണ്. ഇനീഷ്യേഷൻ ഡോസിൽ എന്ന് പറയുമ്പോൾ വാർഫറിൻ നമ്മൾ ഫസ്റ്റ് സ്റ്റാർട്ട് ചെയ്ത പേഷ്യന്റ് ആണ്. അപ്പോൾ ഫ്രീക്വന്റ് ആയിട്ട് നമ്മൾ INR മോണിറ്റർ ചെയ്യണം every 2 to 3 days. മെയിൻ്റനൻസ് ഡോസിലാണെന്നുണ്ടെങ്കിൽ മെയിൻ്റനൻസ് ഡോസ് നമ്മൾ സ്റ്റാർട്ട് ചെയ്യുന്നത് പേഷ്യന്റ് INR സ്റ്റേബിൾ ആയതിനു ശേഷമാണ്. So every week we need to check INR still if it is out of range, and once it's you find it's therapeutically stable, you need to check only monthly, I mean every 4 week. This is the protocol for maintenance dosing. In case of regular intensity anticoagulation of INR 2 to 3, our target is in between 2 to 3, and if you find the INR is less than 1.5 in the targeted INR of 2 to 3, you need to increase the weekly maintenance dose 10 to 20%. Here you can consider one-time supplemental dose of 1.5 to 2 times daily the maintenance dose. Could explain here. Number target INR 2 to 3 ആണ്. If you find INR like 1.4 or 1.3, നമ്മുടെ മെയിൻ്റനൻസ് ഡോസ് നമുക്ക് 10 to 20% ഇൻക്രീസ് ചെയ്യാം. ഫോർ എക്സാമ്പിൾ ഒരു പേഷ്യന്റ് ആൻഡ് വീക്ക്ലി ഡോസ് 30 milligram per week ആണെന്നുണ്ടെങ്കിൽ 5 days 5 milligram and then another 2 days 2.5 വെച്ചിട്ടാണ് യൂസ് ചെയ്യുന്നുണ്ടെങ്കിൽ we can change to 5 milligram daily. That is it will be 7 by 5 35 milligram per day. So if it is only less than 1.5, and one-time supplemental dose can give the weekly dose in the 1.5 times. We are giving 5 milligram daily, so instead of that we can give the first time we can give 7.5, then subsequent days we will give 5 milligram. So first dose 7.5 to or 10 milligram vare 2 times vare namukku use cheyavunnanu. If the INR is in between 1.5 to 1.7, that range, you have to increase the weekly maintenance dose 5 to 15%. So INR kodunnanusaരിച്ചിട്ട് നമ്മുടെ weekly maintenance dose ന്റെ percentage നമ്മൾ കുറക്കുന്നു. ഇവിടെ നമുക്ക് supplemental dose 1.5 to 2 times as a maintenance dose ആയിട്ട് കൊടുക്കാവുന്നതാണ്. And for the targeted INR 2 to 3, 1.8 to 1.9 on INR range എന്നുണ്ടെങ്കിൽ we don't need any dose adjustment. If the last 2 INR, previous 2 INR values check ചെയ്തിട്ട് if it is normal, no need to have any further dose adjustment. If you need any further dosage adjustment, increase the weekly maintenance dose by 5 to 10%. As usual, you can consider one-time supplemental dose of 1.5 to 2 times daily maintenance dose. If the INR is 2 to 3, that is the therapeutic range. So no adjustment is needed. We can continue the current dose. And now we talk about the INR is out of range. I mean the above the normal limit. If it is just above 3 to 3.2, no dosage adjustment is necessary. if there is the last 2 INR. If the last 2 INR, if it is in the normal stage, we don't need to have any further dose adjustment. If it is in between 3.3 to 3.4, we need to decrease weekly maintenance dose 5 to 10%. Previous case, we increase the percentage decrease. If the INR is more than 4 but less than 10 and no bleeding, hold the warfarin until below the upper limit of therapeutic range. So our upper limit in 2 to 3 or in the other case 2.5 to 3.5, both range. If INR is above 4.5, we should hold the warfarin until we reach less than 3.5 or 3 in the other group. And we need to hold and then decrease the maintenance dose by 5% to 20%. And if you think the patient have a significant risk of bleeding, we need to give a low dose oral vitamin K. And in case if the INR is more than 10, and all the cases, if the INR is above the limit like 5 or 6 or until 10, there is no chance of bleeding. It depends upon the individual patients. Always it depends upon the individual patient characteristic. So if it is more than 10 and no bleeding, you have to hold warfarin until INR below the limit and administer vitamin K orally. And you have to decrease the weekly maintenance dose 5 to 20%. So this is how we manage warfarin therapy after initiation and the maintenance dosing. So what are the factors affecting warfarin dosing? Age is an important factor. The geriatric patient, those patients with age more than 75 has a high risk of bleeding. So they have to give a lower dose compared to the normal adult patients. And female sex has more prone to more bleeding risk compared to male sex. So females has to be considered with a lower dose. Hepatic dysfunction, warfarin is metabolized by the liver. So if there is chronic hepatic failures, then we should consider either it's contraindicated in case of liver failure, or if there is hepatic dysfunction, you need to reduce the dose. Another nutritional status, patient's nutritional status, vitamin K intake, this also affects the dosing of warfarin. Malignancy, especially the malignancy in the GI tract, gastrointestinal tract, there is a chance of bleeding, severe bleeding in that area. Renal disease, patients with the end-stage renal disease, it's better to avoid warfarin. It's not safe to use in patients with end-stage renal disease. We have different INR and different dosing in cardiac valve replacement and acute infections and inflammations. Our hemodynamic status will change with any severe infection or inflammation. So this will affect also the INR of the patient. And finally, about drug interaction. This is one of the major factors we need to consider while using warfarin. Most of the drug interaction affect INR within 3 to 5 days of the concomitant therapy. So drug interaction, interacting drug use within 3 to 5 days, the result INR result. So here we examples into fluconazole, metronidazole, or Bactrim. The first day of interaction, you need to decrease the weekly warfarin dose by 30%. 30% dose decrease. So it depends on the liver enzyme elevating the liver enzymes suppressing the drugs in the depend on the time. So every 3 to 5 days we need to recheck INR. In case of amiodarone, these are some examples. In case of amiodarone, after 7 days of concomitant therapy of amiodarone and warfarin, we need to decrease the weekly warfarin dose by 25%. Check INR after 7 days. Then after 14 days, again decrease another 25%. And after check INR after 14 days. Then after 21 days of the dual therapy, if the INR is within the goal, then follow the maintenance INR monitoring table. In case of rifampicin, it's just opposite. Day 7, we need to increase the weekly warfarin dose because it will induce the liver enzyme. Then 14, just increase the 25%. You need to check INR every 7 days, 14 days. And after 21 days, if it is goal, within the goal of INR, you can continue the maintenance dose. You can have follow the maintenance dose. For all other drug interaction, adjust the weekly warfarin dose if INR is outside of therapeutic range after INR check, and you need to check every 3 to 5 days. So drug interaction or major factor ആണ് കാരണം നമ്മൾ warfarin dose the normal dose approximately 30% or amiodarone കേസിലാണ് 50% വരെ നമുക്ക് എന്താ ഡോസ് റെഡ്യൂസ് ചെയ്യേണ്ടി വരും. Then finally, reversal of warfarin. This depends upon the bleeding. In case if the INR is 5 to 9 and there is no bleeding associated with this, first of all, I told you before, if it is the INR is above 4, first we need to hold the warfarin. So hold the warfarin dose. Do not administer vitamin K in case of low bleeding risk. If there is a high bleeding risk, especially in the elderly or patient have bleeding history, we need to administer vitamin K 1.25 milligram per hour. Monitor INR frequently if possible. If still there is a chance of bleeding, or if there is bleeding, if there is a chance of bleeding, you have to give vitamin K. If the bleeding absent and the INR is more than 9, hold warfarin dose and give vitamin K more dose 2.5 to 5 milligram and repeat if necessary. Monitor INR frequently if daily possible. If it is more than 5 and there is minor bleeding, you need to discontinue warfarin and you can go to choice of IV vitamin K. In case of major bleeding, regardless of the INR, because we need to discontinue warfarin first, you can give vitamin K 10 milligram IV. And if still if you feel if still there is risk, prothrombin complex concentrate PCC is recommended for the rapid reversal. What are the advantages of warfarin? So we have the data from the 50 years of extensive studies and specific reversal reagents available with this, and it's not affected by the renal function. Only it's contraindicated in end-stage renal disease. Frequent INR monitoring assure compliance, and it is low cost. And what are the disadvantages? We saw it is affected by the many drugs, either liver enzyme elevating drugs or suppressing drugs. So it has a major drug interaction. And also it has a food interaction with vitamin K containing food, the green leafy vegetables, and all this. And frequent INR monitoring. It is inconvenient for the patient. And it's also the overload for the clinic. And the complex dosing is another disadvantage of warfarin. So what are the patient education we need to provide in case of warfarin therapy? First, about the indication, the patient has to be educated why they prescribe the warfarin, what's the purpose, what will happen if he does not take the medication, and how the medication works. Especially, we need to advise the patient about the risk of bleeding, and onset and duration of activity, dosing frequency and duration. Duration of therapy, especially in some cases, it's lifelong, and some cases we need to use a short-term period. And another one, most important, the patient, we should teach the patient about the bleeding signs and symptoms, like vomiting, blood, bruising, pink or reddish brown urine, nosebleeds, any broken blood vessels in the white part of the eye, or normal than heavier menstrual bleeding, normal compared to the normal. These are some of the signs of bleeding symptoms. So patient should be aware about these conditions. And we should inform the patients to notify other healthcare providers that they are on warfarin therapy, especially if they prescribe any other interacting medication or some procedures like some dental procedure, minor surgery. In this case, it's very important to inform the healthcare. So patient should be aware about this. And missed dose instruction. It's like all the medication, like common all medication. The missed dose is, if there is a missed dose, the patient has to take immediately when he remember. But he should not take, if he is sure he missed 2 doses, is not advised to take 2 doses on the same day. It will put him high bleeding risk. And patient should understand the need of INR testing and the goal of INR. And finally, vitamin K dietary consistency. This is one of the most important most important point to counsel the patient about those who take warfarin, because even their dose is also depends upon the vitamin, how much vitamin K content diet they are taking. So they have to take a consistent. It's not necessary to avoid all vitamin K containing food. They have to take a consistent vitamin K containing food, and they should know how much vitamin K in their daily meal, and don't change suddenly the total vitamin K intake, or too much food which containing vitamin K. And also they are not advised to take any multivitamin products without consulting the physician. So especially the bleeding signs and about the dietary consideration, we need to have special counseling for the patients. So these all are about the warfarin. And then we go to the DOAC, the direct oral anticoagulant. As I mentioned earlier, the direct oral anticoagulant, it came to our market after 2010. And before this period, the warfarin was among the oral anticoagulant, warfarin was the only choice and along with the other parenteral medications. So these include the direct factor 10A inhibitor and direct thrombin inhibitor. So we are using the rivaroxaban and Apexiban is the most commonly used factor 10A inhibitor. It was used for preventing deep vein thrombosis and pulmonary embolism related issues. But there were many clinical trials and studies had been carried out to prove the safety and efficacy of rivaroxaban in other disease states other than this traditional use. So there are some clinical trials regarding the use of rivaroxaban in atrial fibrillation, non-valvular atrial fibrillation. It has proven that it is not inferior to the therapeutic effect of warfarin. So in that case, we can go, if the patient has no risk factors with rivaroxaban, we can go to this dosing. The advantage is the patient does not need to monitor the INR frequently. So the dose for this case is 20 milligram daily with food. And in case if the creatinine clearance is in between 15 to 49, the dose should be 15 milligram per oral daily. In case the creatinine clearance is less than 15 and the creatinine clearance less than 30 and patient age, those who have 30 and patient age more than 65, the use is not recommended for this indication. So in each indication, the dose or the frequency is different. Still, there are many studies and many clinical trials, randomized studies are going on. For a percutaneous coronary intervention, these are the off-label use from the evidence-based therapies. So from these, the dose, the 15 for the percutaneous coronary intervention, the 15 milligram daily aspirin. You can use 15 milligram daily aspirin with clopidogrel. In coronary artery disease, it's also off-label use. It's not approved by the FDA. That's why we call off-label. The 2.5 milligram BID as an add-on with clopidogrel or aspirin. In case of heparin-induced thrombocytopenia, 15 milligram daily with food for 21 days or until the platelet count recovery. So whichever is longer, followed by 20 milligram once daily with food. In case of peripheral artery disease, 2.5 milligram twice daily need to administer in combination with the daily low dose aspirin. In superficial vein thrombosis, the dose is 10 milligram daily for 45 days. In deep vein thrombosis and pulmonary embolism, 15 milligram BID for 21 days, then 20 milligram daily. So after 21 days, you need to continue 20 milligram daily indefinite. Avoid the use of medication in severe or hepatic impairment. For VTE prophylaxis, 10 milligram daily for total duration of 31 to 39 days. And it is not recommended to use if the creatinine clearance is less than 30 ml per minute. In non-major orthopedic surgery of lower limb, it's an alternative therapy. It's off-label use, not yet approved by the FDA. But still we are practicing this. 10 milligram daily, and it has to be initiated within 6 to 10 hours after the surgery or when the hemostasis is established. The minimum is 10 to 14 days, maximum up to 35 days. So some cases it is indefinite treatment, and in some cases it is for a limited period of time. That's about the duration of the therapy. The duration of the actual duration of the therapy is unknown. It depends upon the many risk factors, whether the provoking factors are present or patient risk factors for recurrence of bleeding. So the provoking factors of provoked venous thromboembolism, it is for 3 months. The provoking factors like chemotherapy or immobility or use of hormonal contraceptive, these are the provoking factors. And in unprovoked venous thromboembolism or with provoked venous thromboembolism with persistent risk factors, if the risk factors are still there, we have to use more than 3 months. Depends upon the risk of VTE or the recurrence and bleeding. Now, finally, how we will switch from one anticoagulant to other, from low molecular weight to heparin or fondaparinux. If the patient is on heparin or fondaparinux, start rivaroxaban within 2 hours prior to the next schedule dose of parenteral agent. So we can start 2 hours before when we start the next dose of heparin. In case of bivalirudin or unfractionated heparin, you can start immediately after the parenteral anticoagulant stop. For warfarin, you cannot start immediately because the half-life of warfarin is maybe to last 2 to 3 days. So discontinue warfarin and initiate rivaroxaban as soon as INR falls less than 3 or less than 2.5. So in case of warfarin, we have to wait. We have to check INR before starting the rivaroxaban. And if you want to change from rivaroxaban to other agents like unfractionated heparin or low molecular heparin, fondaparinux, you can start straight when the next dose of rivaroxaban is scheduled to be given. In case of rivaroxaban to warfarin, the rivaroxaban will elevate the INR, so it will rivaroxaban itself will interpret the overlap in INR, and it will interpret the overlapping with the INR. So to minimize the interference, check INR near the end of rivaroxaban dosing interval. So rivaroxaban and dose then INR value changes വരുത്തും. So end of rivaroxaban dosing interval INR check ചെയ്തിട്ട് വേണം നമ്മൾ വാർഫറിനിലേക്ക് സ്വിച്ച് ചെയ്യാൻ. Or you can start warfarin the same day and bridge with a parenteral anticoagulant like low molecular weight heparin until you reach the desired INR. Next in this category of 10 inhibitor is Apexiban. We go directly to the indication. For the heparin-induced thrombocytopenia, this is off-label use. 10 milligram twice daily for 7 days until the platelet count recovery is achieved or whichever is longer. In non-valvular atrial fibrillation, to prevent stroke and systemic embolism, the dose is 5 milligram BID. So always the dose of Apexiban is BID, depends upon the patient stage, either it's 5 milligram or 2.5 milligram. It is very important for patients, those who aged more than 80 years or their body weight less than 60, those who have serum creatinine more than 1.5, need to reduce the dose 2.5 milligram twice daily instead of the 5 milligram dose. And in case of DVT and pulmonary embolism, 10 milligram twice daily, initially for 7 days, and followed by the 5 milligram twice daily. Venous thromboembolism prophylaxis, 2.5 milligram BID, and the beginning 12 to 24 hours post-operatively. After the operation, 12 to 24 hours, then 10 to 14 days, or up to 35 days, we need to continue as a prophylactic treatment. The transition is almost similar. Initiate Apexiban in case of fundaparinax, or low molecular weight heparin. You can start directly when the next scheduled dose of parenteral anticoagulant, and from unfractionated heparin to Apexiban, you have to start when the Apexiban is when the unfractionated heparin is stopped. From Warfarin to Apexiban, discontinue Warfarin and initiate as soon as the INR falls less than 2. And from Apexiban to other medication, you can start directly when the next dose is to be scheduled. And in case of Warfarin, check the INR near the end of Apexiban dosing interval. Once desired INR is reached, you can start. From other direct anticoagulant, start when the next dose of the previous direct anticoagulant is scheduled. So you can, when you want to switch from Apexiban to rivaroxaban, they can start directly from when the next dose of Apexiban or rivaroxaban is ready to take. And the next one is endoxaban. It's used for non-valvular atrial fibrillation to prevent stroke and systemic embolism. In this case, the recommended dose is 60 milligram daily. It's not recommended to use endoxaban in case of non-valvular atrial fibrillation if the creatinine clearance is more than 95 ml per minute. If the creatinine clearance is more than 95, it means it's normal. So the medication, the 80% of this medication is excreted through the urine. So if the creatinine clearance is normal, the therapeutic, it will be in subtherapeutic level. In post-percutaneous coronary intervention, stent replacement, 60 milligram daily. You can administer with an appropriate antithrombotic agent, clopidogrel or aspirin, in deep vein thrombosis and pulmonary embolism. After at least 5 days of initial therapy with parenteral anticoagulant, you can transit to endoxaban in case of hemodynamically stable patient. So endoxaban case, if the creatinine clearance more than 95 ml per minute non-valvular atrial fibrillation recommend the efficacy will be less. And about the transition from unfractionated heparin to continuous infusion to endoxaban, you can initiate when the continuous infusion is stopped. This is, most of them are similar like the previous cases. And in case of warfarin, discontinue warfarin and initiate the INR falls less than 2.5 or equal to 2. If you want to make transition from, you want to change from endoxaban to warfarin, for the patients taking endoxaban 60 milligram daily, first we need to reduce the dose to 30 milligram once daily, and you can start warfarin concomitantly. For those take 30 milligram, just reduce it to 15 milligram. So in both cases, reduce the dose to the half, and you have to use together concomitantly warfarin and endoxaban. And you need to measure INR at least weekly and just prior to the daily dose of Anticoagulant to minimize the influence of Anticoagulant on INR. And finally, discontinue Anticoagulant once the desired INR is achieved. And the last one is dabigatran. This is the only oral anticoagulant which act as a direct thrombin inhibitor. For prevention of stroke and systemic embolism, the recommended dose is 150 milligram BID with regard to meals. If the creatinine clearance is less than 15, the use is not recommended. For DVT and PE prophylaxis, 110 milligram first, then 220 milligram daily for 28 to 35 days. Not recommended if the creatinine clearance is less than 30 ml per minute. For VT prevention, 150 milligram BID and treatment with parenteral coagulant for 5 to 10 days. And if avoid use if the creatinine clearance is less than 50 ml per minute or concomitant plasma glycoprotein inhibitor drugs. So what are the adverse drug reactions and contraindication adverse of the direct oral anticoagulant? This is similar to warfarin. The most important thing you need to consider is the bleeding. So patient has to be instructed about the signs and symptoms of bleeding, bruising, anemia. Patient need to check the complete blood count has to be checked before treating and then every year. The other common side effects like nausea, vomiting, rash, itch, some patients may experience. And in case of dabigatran, it's reported 20% of patients with dabigatran have experience of stomach upset and dyspepsia. And the contraindications, as usual, the hypersensitivity to any direct thrombin inhibitor or factor Xa inhibitor, and patients with mechanical valves or bioprosthetic valve, we cannot use any of these agents because for the mechanical valves, warfarin is the only one choice. And pregnancy, it's not studied in the pregnant population. So the low molecular weight heparin remains the only drug of choice. And all these direct acting on oral anticoagulants are pregnancy category C, and there is no extensive studies in a human population. End-stage renal disease, warfarin is the only drug of choice in case of end-stage renal disease. And also, finally, the individuals younger than 18 and pediatric patients, there are no much studies to prove the safety or efficacy of the these direct agents. At the end, the reversal and pre-operative management. Warfarin, we already discussed about warfarin, how we can reverse the warfarin. It's done by either vitamin K or prothrombin complex concentrate if it's not controlled by the vitamin K. So what is the pre-operative management? Before, this is very important to counsel patient about what precautions they have to do before they go for any surgery. So they need to hold warfarin at least 5 days before surgery. Depends upon the urgency of surgery or procedure, or they can be given low dose IV vitamin K. For minor procedure, they are recommended to continue warfarin and discontinue use just 2 to 3 days prior to the dental procedure or any minor procedure. In case of dabigatran, there is reversal agent available as the new monoclonal antibody, idarucizumab. If it's not available, we can still use the factor for prothrombin complex concentrate. Before any surgery procedure, minor or major, if the creatinine clearance is more than 50, you need to hold 1 to 2 days before the surgery. If it is less than 50 ml per hour, ml per minute, you need to hold 3 to 5 days before the surgery. And Apexiban, there is a new agent available as a reversal agent. It's called Apexiban alpha. For the low bleeding risk procedure, need to hold before 24 hours. For a high bleeding risk procedure, need to hold 48 hours prior to the procedure. So in case of major surgery, you need to hold before 2 days. Endoxaban and rivaroxaban also has the same, can be used the same reversal agent, and it has not enough studies in humans, but animal studies has proved its efficacy. For lower bleeding risk, hold 24 hours prior to surgery, or for high bleeding risk, 48 hours for both rivaroxaban and endoxaban. And what are the parameters, monitoring parameters for we need to consider for using the direct oral anticoagulants? Serum creatinine and creatinine clearance, baseline and annually. So before starting this medication, we need to check the serum creatinine and creatinine clearance. And for every 6 months, if the creatinine clearance is 30 to 60 ml per minute, or the patient is on dabigatran, or if the patient more than 75 years old. And liver function has to be monitored annually. Signs and symptoms of any bleeding and complete blood count has to be monitored every year. Weight, interacting medication, upcoming procedure, and finally the compliance and affordability of the medication has to be checked with the patient in each visit. Thank you. That's all. Hello.